आपके पड़ोसी।
गुड इवनिंग सर।
है उसमें जितेन सर, एक 2 मिनट के लिए आप थोड़ा स्क्रीन वो करें ऑफ, सो दैट
जो डॉक्टर पंकज चौधरी या रीवा मेडिकल क्लास आपके उसमें सब प्रोफेसर लोगों को एक साथ बुला लिया है।
अरे
वो
सर,
हमारा वो भाग्य है।
सर प्रोफेसर तो आप ही हैं सर आज।
नहीं नहीं, मैं प्रेसिडेंट मीडिया हूँ, ये मान सकता हूँ, प्रोफेसर नहीं भाई।
सर
चलिए, आई थिंक यस वसुधा, वी कैन स्टार्ट नाउ।
you can start now.
Yeah.
Okay. So I welcome you all as Secretary BDOS on behalf of Bhopal Divisional Ophthalmic Society in Gurukul, our 4th online masterclass for postgraduates and comprehensive ophthalmologists. And today we have got a very eminent speaker, Dr. Jitendra Jithani from Vadodara, and he's director of Baroda Eye Care and Squint Clinic. So we welcome you, sir. And I welcome all the panelists. Dr. Viren Jha, he's practicing at Indore. He's doing an excellent work in pediatric ophthalmology. Dr. Rashmi Apte and Dr. Kavita Gupta, our young dynamic ladies, both of them are consultant at Seva Sadan Eye Hospital and are doing excellent job in the area of squint and pediatric ophthalmology. Dr. Suraj Kubre, working as an associate professor at Gandhi Medical College, having an excellent surgical skill, and overall he's a very good oculoplastic surgeon and anterior segment surgeon. Dr. Praveen Khare, professor and HOD Bundelkhand Medical College, again a very good surgeon, clinician and an excellent teacher. I welcome all the postgraduates, Dr. Natasha from GMC, Dr. Ashwati from BMHRC, Dr. Aditi from SS Medical College Viva, and Dr. Yashaswini from RKDF Medical College. Now, let me introduce about our speaker today, guest speaker today, Dr. Jitendra Jithani. He did his graduation from BJ Medical College, Ahmedabad in 1999 and MS from Regional Institute of Ophthalmology, Ahmedabad in 2022. And he has done DNB in 2002 he has done his MS. Now he did his fellowship in pediatric ophthalmology at Arvind Eye Hospital and also short-term fellowship from University of Wisconsin and also awarded fellow of All India Collegium of Ophthalmology in pediatric ophthalmology and squint in 2011. He worked as assistant professor at RIO and as a head pediatric ophthalmology and strabismus at Dr. Thakorbhai V. Patel Eye Institute from 2008 to 2016. Currently, he is director of Baroda Children Eye Care and Squint Clinic. Received so many awards. I was just going through his CV, endless record of the awards in his account. He has received gold medal on pediatric cataract in BOS, Vishisht Chikitsa medal, E.T. Selvam Award for Best Poster in AIOS in 2010, Prem Prakash Disha Award for Best Paper in Squint Session in AIOS 2011, IIRSI Special Gold Medal in 2011, Best Video Award at Prabhudeep Video Film Festival in 2012, Best Publication of the Year and Best Paper Award at Strabismus and Pediatric Ophthalmology Society of India, Hanmant Reddy Award for Best Paper in Pediatric Ophthalmology in AIOS, AIOS Optic Award for his pioneering work on low concentration of atropine eye drops for halting the progression of myopia, Athavale Award, Best Paper Award at All Gujarat Ophthalmology Society for a new prism holding device in 2019. He was Secretary of Baroda Ophthalmic Society and was Chairman Scientific Committee of All Gujarat Ophthalmological Society. He was editor, Journal of Strabismus and Pediatric Ophthalmology Society of India. He is presently section editor of Indian Journal of Ophthalmology. He has to his credit 58 scientific publications in peer-reviewed index journal and 120 scientific presentations at national and international level. So we welcome you, sir. And this time we are having an online class that is under Gurukul, and we'll like to listen from you sometimes in live sessions also. And I'm sure that you'll definitely enjoy our city of lakes, that is Bhopal. Now I request Dr. Gajan Chawla sir for his address, and Dr. Jiten sir, you can also start sharing your slides. Just few minutes more.
Thank you,
Dr.
Dr.
Gajan sir.
Vasudha. Thank you, Dr. Vasudha, for a very vast and very exhaustive introduction of Dr. Jitendra. I just want to, before I welcome each and everyone, including Dr. Jitendra Jethani, our professors from RIVA, Dr. Pankaj Chaudhary, Praveen Khare, Suraj Kubre, Aditi, and so many professors and the senior people are here for this new session or new master class on the squint. You have given a wonderful introduction of Dr. Jiten Jethani. I just would like to add one more thing. He is having roots in MP. So his in-laws are in Katti. So ये कहना चाहिए हमारा MP के लिए जो है वो हमारा जवाई है, हमारा दामाद है. तो एक नाता वो भी है हमारे साथ में. But squint per se is a very interesting topic, and when I was doing my post-graduation, and probably all the postgraduates who are here, उस समय तो ऐसा डर लगता था कि यार वो क्या स्क्विंट, व्हाट इज स्क्विंट, हाउ इट विल बी, एंड इट वाज इनएविटेबल कि आपकी पोस्ट ग्रेजुएशन एग्जाम में देयर विल बी ए केस ऑफ स्क्विंट, and everybody was scared, including me. So I remember, I'm recalling Dr. Salil Kumar was my senior. Unfortunately, we lost him last year, but he was very good in the squint evaluation and assessment of the squint patient and treatment. So he taught me when I was doing my post graduation, and जैसा सबके साथ होता है, मुझे भी I got a squint as in my long case. So, but the way he has taught me, so probably I could perform good in that case, and it went on well. So now, at that time, the only our seniors in the college or in medical college, they were our teacher, and they were guiding us. But now, since the so things has been changed, especially after COVID, so we are having a national and international connectivity through the online. So now our postgraduates are lucky, so they are directly going to learn how to evaluate the squint with the master, Dr. Jiten Jethani. So I will not take much time and invite him to take his class, a master class by Dr. Jiten Jethani. Welcome, Dr. Jiten, sir.
Thank you so much, sir. Thank you so much for the warm welcome, and thank you so much for the kind words for the introduction. I just want to say that it's really a privilege to speak in front of the teachers and professors. I hope I can do justice to the topic. So basically, what we do in strabismus evaluation is that we divide it majorly into two broad groups.
सर आपकी आवाज भी नहीं आ रही, स्क्रीन भी फॉरवर्ड नहीं हो रहा है, जितेंद्र सर.
Jiten sir, you are not audible, and
screen
you can reshare your screen. Yes.
He's trying.
Okay.
He's rejoining.
Is first and foremost thing is that we want to find out whether first and foremost is that we want to find out whether there is any presence, and if there is a presence of strabismus, what is the type of strabismus. Second thing is whether there is any presence of amblyopia or not. So if there is presence of amblyopia, then we have to treat the amblyopia first, and that is why it is so important. The third thing is what is the amount of deviation, because if we want to measure, if we want to operate, or if we want to treat the patient of strabismus, we have to measure the amount of deviation. And finally, the fourth part, that is assessing or the sensory part of the whole examination process. The clinic. I know this is part of the pediatric ophthalmology and not truly about strabismus, but before we know that what is normal, what is abnormal, it is very difficult to discuss or talk about, whether the patient has strabismus or not. So sometimes, patients will come to you and they will tell you that the kid is 2 months old and patient is having a small exo. We all know that, you have to the first and foremost thing is that fixation should be well developed. So to check for the fixation, if the fixation is there, only then we can think about strabismus. So these are some of the normative things. These are some of the normative data that we should be aware. By 30 weeks of gestation, there is pupillary reaction. So if you put light in mother's womb, you will the pupil actually constricts before birth also. At birth, doll's eye movement is present. By 4 to 8 weeks, fixation is well developed. But most important thing is, I remember one of our resident doctors had come to me. The resident doctor had the first baby, and when the baby was around 1 month, the child was still not looking or not moving vertically, and he felt that probably there is a supranuclear gaze palsy. But we all know that by the time the kid is 8 weeks, the kid would start seeing vertically. So if vertical movements are not there at birth, it is completely fine. And then gradually the kid would start fixing. There will be foveal differentiation, and gradually the stereopsis will come by 6 months and by 9 months. So by 6 months, by 4 to 6 months, if there is any presence of strabismus, then we are confirmed, we are sure that this particular patient would need some intervention. Before 4 months, if there is a small ESO or small exo, we have to wait till 4 months of age so that it can get automatically corrected. Now, these are just the normative milestones so that we know what is to be expected. Now, this is another important test before we talk about strabismus, because this is actually the baseline. We always say that once you have the proper accurate refraction in place, only then you can assess it further, because the moment you change the refraction, you would see that there will be change because of accommodative convergence, because of fusional convergence. There will be a change in the ocular pattern of movement also. So we need to do accurate refraction, always do cycloplegic refraction. Atropine 1% is the gold standard, but nowadays in most of the patients, if there is esotropia, only then we go for atropine. Otherwise, we do home atropine eye drops. We use home atropine eye drops. We can use cyclopentolate eye drops. A lot of times, I am asked that whether we should use cyclopentolate eye drops or not, and we keep telling that cyclopentolate eye drops are good, but sometimes what happens is that the kid may be having some developmental issues, and these drops are not they can create some psychosis or problems like that. So home atropine drops are currently our favorite. We use them. We come to the motor evaluation. What are the goals for motor evaluation of strabismus? First and foremost is to measure strabismus, but before that we have to tell whether there is any presence of strabismus or not. Second is to do a corneal reflex test. Third is cover test. And finally, we will talk about assessing ocular motility. Now, cover test, basically, I remember from my post-graduation that our teachers used to tell us that if you know how to do cover test, then not half, but 80% of your work is done, because cover test is like an overarching, an umbrella term, and cover test itself has small terms inside that. So what do you need for cover test? and what exactly is cover test. So the left part of the slide is talking about what do you get out of cover test. So there used to be a short note where we used to write all these things. The cover test tells you about the type of deviation, whether it is EXO or EXO. It tells you whether it is a tropia or a phoria. So tropia means that you can see there is a manifest strabismus. The moment patient walks into your clinic, you know that this particular eye is inside or outside. What does phoria means? Phoria means that the deviation is hidden. You are not able to see the deviation, and you have to do something to break the fusion to know what is the type of deviation. And then the cover test also tells you whether it is a unilateral or an alternate squint. Now, this is different from alternate cover test. We will talk about it, but at this point of time, we should know that it can tell us whether the patient is able to alternate his tropia or there's a unilateral deviation. Remember, I am saying it is about alternate tropia. Phorias would be alternate because they are hidden. So the eyes are practically straight. So we are not discussing phorias when it comes to alternate tropias. We will talk about this. The second point is the amount of deviation. The cover test will tell you, the prism cover test will tell you how much is the amount of deviation. And on the basis of that, you would be performing a certain amount of surgery to improve the squint or to improve the misalignment. Cover test also tells you whether there is a latent nystagmus, whether there is a poor fixation in one of the eyes, whether the eye is emblyopic or not, whether there is any presence of latent nystagmus, whether the deviation is incomitant or not. Fixing right eye, fixing left eye, if you measure the angle, fixing sound eye is the angle which is primary, and fixing unsound eye is the angle which is secondary. Then you can know about if there is a difference between fixing right eye, fixing left eye, it means that there is incomitant deviation. Whether there is any presence of amblyopia, whether there are any dissociated deviations. Now, dissociated deviations are also incomitant deviations without following the Wiring's law. So dissociated deviations mean that when the patient is sufficiently dissociated, one of the eye would go out. This is what is dissociated deviation. And the cover test has subtypes like cover uncover, cover test, cover uncover test, alternate cover test, prism cover test, and corneal reflection test. Now it is not in the order of performance. So cover test, cover uncover test, alternate cover test, prism cover test would be done when there is good vision in each of the eye. And corneal reflection test is basically more of an inspection. So when the patient walks into your clinic, you can do a corneal reflection test. You can take a TOT. So it is more of a subjective kind of test. It doesn't tell you about the amount of deviation. You have to do a Krimsky's test. We will see all these tests in detail. What are the tools that you need? So you would always need, see, never do cover test with torch. If you want to know what is the deviation, if you want to really do it, use a fixation target. Why do you want to use a fixation target? Because you want to control the accommodation. When the patient is looking at a distant target, you know that patient is looking at a distance and his accommodation is at rest. When the patient is looking at a near target, you know that as per the distance, if he is seeing the target at 33 centimeters, he is using an accommodation of 3 diopters. So this is well within your knowledge that 3 diopters of accommodation is being used, and this will induce some amount of convergence. So you take that into consideration. Second thing is occluder. Now you can use your hand, palm of your hand, which is okay, but it is better to use an occluder because it is more hygienic, it is more precise, and patient also feels that you are using some device. Third thing is you can, if the kid is small, you can always use palm of your hand. There is nothing wrong in that. The only thing is you should be covering the eyes sufficiently that patient should not be able to see through the gaps of your fingers. So you have to use something which completely closes that particular eye. At the same time, you should not be pressurizing the eye or touching the eyelid. Third thing is torchlight. Now, torchlight is not needed to do a cover test, but you would need torchlight to know what is the corneal reflection test. So you are using torchlight mainly to do a corneal reflection test. And finally, you need prisms, either prism bar or you can use a loose prisms. Now, prism bar or loose prisms are mainly to measure the amount of deviation. The first and foremost test is
corneal reflection test. What you do here is pretty simple. Patient is sitting right in front of you. You have taken a torch, and what you do is you try to estimate the amount of deviation with the help of the amount of eccentricity of light reflex from the center. Now, if you take eye as a round thing, this is a cover test. Now, if you take as a round thing, if the light is at the nasal part of the center of the pupil, then the eye is on the outer side and it is exotropia. If the light reflex is temporal, the deviation will be called as esotropia. Now, how do we know that each mm of eccentricity amounts to an angle of 7 degrees? By definition, if the light reflex is at the limbus, it will be 45 degrees. The corneal diameter is 12 millimeters. We will half the corneal diameter because we are looking at the center. So that is 6 millimeters. For each millimeter, so 45 divided by 6 will be approximately 7 degrees. So for each millimeter of eccentricity, so it is basically like we are giving a technicality to a non-technical test. So there is no point in, this is mainly to understand the test. This you don't have to use this particular test to measure the deviation. It is just a empirical thing to write that there is an exo of 20 degree. Nobody will operate on the basis of degrees. Nobody will operate on the basis of empirical thing. You have to do a cover test, and only then you can operate the patient by finding out the amount of deviation. But this is just a basic test which we should know. Now, this is cover uncover test. What we are doing here is, see, I'll come to that. So after Krimsky, we come to cover test and cover uncover test. Now, cover test means what? Cover test is first and foremost done in a tropia. What does tropia mean? Tropia means there is a manifest deviation. Now, in this particular illustration, what we can see is that the left eye is out. So that is left eye exotropia. This is from corneal reflection. We know that left eye is out. This is tropia. What we will do is, we will cover the right eye. Now this is, what did we do? We covered the right eye. And then what we do? We wait. What happens? The left eye takes up the fixation. It comes from outside to in. And what is the next step? We do cover, uncover test. We uncover the eye, right? I will tell you. We'll go, this will come again. So this is what is cover test. So what is cover test? You cover the seemingly fixating eye, which means that the eye which is out is not to be covered. The eye which is fixing is to be covered. Why? Because the eye which is out is already telling you that this particular eye is out. So by covering that eye, you don't get any new information. So you cover the seemingly fixating eye and you observe the response of non-fixating eye. Pretty simple, straightforward. The eye which is out or in or up or down is not to be covered. You have to cover the fixing eye, the eye which is looking at you. You have to cover that eye. And then you have to see the response of the eye which is not fixing. What can happen? Very simple. What can happen? The eye can come from out to in. If it comes from out to in, it is exo. If it comes from in to out, it is eso. If it comes from up to down, it is hyper. And if it comes from down to up, it is hypotropia. This is not very difficult. This is pretty straightforward. You have to cover the eye which is fixing and note the response of eye which is not fixing. Now see this. Now left eye is out. What we will do is, we will not cover the left eye. This is what you should not do. And then what you will do is, you will cover the seemingly fixating. What is happening? Nothing is happening. Nothing will happen because right eye is fixing. So you have to cover. I'm sorry. There was a video which was a googly. Yeah. So left eye is the fixing eye. So what happens is, right eye takes up the fixation. Right eye moves from out to in. We covered this eye. This eye came from out to in. So what is our response? Our response is right eye exotropia. Simple. Then what you do is, you have covered the fixing eye. Once the non-fixing eye has taken up the fixation, you can't hold the cover forever. So what you do is you leave the cover. And what will happen? Only two things can happen. Either the non-fixing eye will maintain the fixation. If it holds the fixation, it is alternate deviation. And if it unholds, loses the fixation, then it is a unilateral deviation. Now, the same patient, we are covering the left eye, and what is happening? No, video is not working. Yeah. Now we uncover. This is uncovering. So the right eye goes back. So what does it tell? It tells that it is right eye exodeviation. The examiner covers the seemingly fixating eye, which is left eye. The eye comes in the center, and then you uncover the eye. The eye goes back. And then the third part is alternate cover test. When none of the eye is fixing, patient is straight. There is no deviation. But the patient says that sometime one of the eye goes out. So any one of the eye can be covered and then uncovered. Next, the eyes are covered alternatively to break the fusion. Because if both the eyes are straight and patient says that one of the eye goes out, it means that patient is holding the eyes. Patient is fusing. Patient is able to hold the eyes with the help of his fusional potential. So you have to break those fusional potentials. And how do you break fusional potential? By doing alternate cover test. Remember, never do alternate cover test in tropia. The patient, see, what happens with our fellows and residents is the moment patient walks into the clinic, we take out our occluder and we do alternate cover test. If you do alternate cover test, what will happen? Your result will be alternate exo. And that is why in most of the files that we receive, it is written alternate exotropia. Why it is alternate exotropia? Because you have done alternate cover test. If you do alternate cover test, you are going to get alternate tropia only. You have to cover the fixing eye if there is tropia. Alternate cover test is only for phoria, manifesting into tropia. You don't have to cover the non-fixing eye if it is a tropia. Should we revise it again? If it is too much of tropia and phoria? See, if there is a seemingly fixating eye, you have to cover the seemingly fixating eye and then uncover it. If there is a phoria, which means that none of the eyes are out or in, both the eyes are straight, then you have to do alternate cover test. This is straightforward. This is alternate cover test. None of the eyes are out. And what happens is you cover one of the eyes and that eye under the cover goes out, and then you go and cover the other eye, and this eye takes up the fixation and that eye goes out. Now you are doing alternate cover test to break the fusion, and then you uncover to see whether that eye is able to go back in the center or not. This is left eye exotropia. This was, see, none of the eyes is out. So you are doing alternate cover test. And when one of the eye is out, what do? You cover the seemingly fixating eye, that is right eye. You will not cover the left eye. And then you wait. That is cover test. And then you do alternate cover test. See, this is, not take this. Okay. Now, once you have established that it is esotropia or exotropia or hypertropia or hypotropia, you have to find out what is the amount of deviation. You have to find out how much is the amount of deviation. Now, to measure the amount of deviation, you have to put the prisms with apex towards the deviation. What it means is that for esotropia, you would be putting base out prism. For exotropia, you would be putting base in prism. For hypertropia, you would be putting base down prism in front of that eye. And for hypo, you would be putting base up. Basically, the apex will be towards the deviation. And gradually, you will keep on increasing the prisms till the point you have the point of neutralization, and then you will go a small prism up to see whether there is reversal or not. How do you write that? You write it on the sense of base out. Like you have to remember by remembering apex towards the deviation, but when you will write in terms of the notification is in terms of base. Base out for ESO, base in for exo, base down for hypo and hyper, and base up for hypo. Now you can see we covered this eye. This eye comes in the center, the eye under the cover goes out. Then we move towards other eye to see whether other eye also takes up the fixation or not. And then you will take an appropriate prism in front of that eye and still do alternate cover test. See, whenever you do a prism cover test, you have to do an alternate cover test because you want to break the fusion and get the maximum amount of prism, maximum amount of deviation. That is, you want to take the tropic part and the phoric part also. So tropia and phoria combined, you get the maximum amount of deviation. Yeah, this is a small video to tell you about prism cover test. Yeah, so you can see that we are gradually increasing the prism. We are giving a target to the patient. We are doing alternate cover test. In prisms, you have to do alternate cover test. This is the bar which we are using. We are gradually increasing the bar. We have got the maximum deviation. Then we go back one prism to see what is the amount of neutralization. And then we see the reversal. And then whatever we get, we put it note down as base in, base out. That was fixing left eye. Now we are seeing fixing right eye. So you always have to calculate the prism cover test, fixing right eye, fixing left eye. Because there may be an incompetence. Any incompetence more than 5 prisms means that there is some problem. Once you have done fixing right eye, fixing left eye, you have to measure the prism in at least horizontal and vertical gazes to know if there is any pattern and to know if there is any other incompetency. Now, there is another interesting test which is known as Krimsky's test. Now, basically, Krimsky test is when the vision in one of the eyes is not good. Now, this particular patient, we can see that the seemingly fixating eye is right eye, left eye is amblyopic. The child was very naughty, so the mother is holding the ears. So when we cover the right eye, left eye takes up the fixation, but it is not able to hold the fixation. See, right eye becomes straight and left eye becomes isotropic. Now, when on doing a cycloplegic refraction, we gave him glasses because it was esotropia. We did cycloplegic refraction, and once we gave cycloplegic refraction, his squint improved. But still, if you see, there is still small ESO which is left. He is on patching. There's no plan for surgery because he is still left eye amblyopic. But still, you can see there is small ESO in the left eye. So, in such patients, when the patient is not able to see good with one of the eyes, we have to use Krimsky's test. And the principle of Krimsky's test is similar. We have to place the prism with apex towards the deviation in front of the fixing eye, that is modified Krimsky, in front of the non-fixing eye, that is the Krimsky as Krimsky has described it. So when you put the prism in front of non-fixing eye, that is Krimsky's test, and when you put the prism in front of fixing eye, like we have done, this is modified Krimsky or Krimsky 2, in which you put the prism in fixing eye. You can see that the left eye is now straight. With this much amount of prism, the left eye is now straight. So basically what you are doing is you are trying to push the non-fixing eye towards center by putting prisms in front of the fixing eye. Okay, now once we have finished cover test, uncover test, alternate cover test, prism cover test, there are few other tests like simultaneous prism cover test and 4 prism base out test, but we will not discuss those difficult tests. We will come back to ocular movements, which are also very, very important, and they are one of the most important part of the motor evaluation. Now, in ocular movements, we have a small classification, ductions. Now, ductions are normally unilateral. So that is abduction, adduction. When you try to look outward, it is when you look temporally or outward, it is abduction. When you try to look nasally, it is adduction. When you try to look up, it is supraduction and infraduction. Now, the difference between ductions and versions is that versions are both eyes together. Dextroversion, levoversion, elevation, depression, these are versions. They do together, they follow the law of Herring's law, equal innervation. Whereas duction, you have to cover one eye and see. So sometimes when you have very large angle, it is possible that because of that large angle, like if patient has large exo, if you try to tell the patient to look on the right side, the left eye may not touch the nasal, the limbus may not touch the punctum. So you may feel that there is some adduction deficiency. There is no adduction deficiency. It is basically the dextroversion where there is some limitation, which is apparent adduction restriction. But if you close the eye and tell the patient to look or to adduct, then he will be able to do that. And so that is what we have to do in all the patients. We have to check monoocular adductions and binocular versions. And then there is convergence and divergence. That also we have to check in all the patients. So before we check the adductions, we should be knowing what are the normal excursions. So these are some videos where we are trying to show how to check the adductions. See, we have closed one of the eyes and we are trying to tell the patient to look at elevation, depression, and the lower video is basically versions. So the versions can tell you about infraoblique overaction, supraoblique overaction, and adductions will only tell about restrictions. See, this is another video. This is just to show you about the infraoblique overaction. The same kid, you can see that left eye is going up. Now, if I close the right eye, the left eye will not go up because the left eye is going up. This is because left eye supraoblique palsy is there, but it is being, but because this is the yoke muscle to the superior rectus, it is going up. If I close the right eye, then left eye will not go up because left eye, then it is ductions. Then we are checking unilateral thing. Inversions, you can see that there is a V pattern downward. There is a esotropia, but see in the right eye, there is not much of infraoblique overaction. But when now you see the left eye has infra and there's a V pattern. So that is the difference between checking unilateral movements and binocular movements. So there is infraoblique overaction. There is accommodated. This particular patient has partially accommodative esotropia, left eye strabismic amblyopia, left eye supraoblique paresis, and V pattern esotropia. Now we move on to another very important point, which is how to measure convergence amplitudes. Now this is also very commonly asked question as how do we measure the amplitudes of the eye. So what do you do in convergence how do you measure convergence amplitudes? Basically, you try to use a prism bar, and first you do a cover test. You do a cover uncover test. It is not showing any deviation. Then you will use a phase out prism. What will phase out prism do? It will deviate the eye outside, and patient has to use some convergence to bring it inside. Remember, we use phase out prisms for esotropia. So what in esotropia we are trying to do? We are trying to bring the eye outward. With using phase out prism, we are trying to bring the eye outward. This is an accommodative target because we are measuring convergence for near. So whenever you are measuring convergence for near, you have to use accommodative target. Whenever you are measuring it for distance, use a target for distance. Now we are doing cover test for near. There is no deviation. Next, what we will do is we will start putting prisms base out. Now this is a base out prism. When you are doing convergence amplitudes, it is easy to use a prism bar because you have to constantly keep on increasing the prisms. It may not be true for normally measuring the deviation. You can use loose prisms, but when you are measuring convergence, you have to use the base is here. You can see the base. So what we are doing, we are gradually increasing the base, and we are trying to see how much patient is able to hold. There will be a point where eye would go out gradually, and patient is no longer able to converge. That is the point of neutralization, or that is the point of reversal, where the eye is going out. Now you have to bring the prism back to see whether he brought it back or not. The difference between these 2 points, the breaking point, point of reversal, and the recovery point. This is the breaking point. Now, the moment you go up, now patient is not, the right eye, you can see it has gone out. You can see that the right eye is gone out. See, I will tell you again. It is in, and the moment we go out, the eye goes, see the eye is out. The right eye is out. This is the breaking point. Once you reach the breaking point, you have to go back to the previous prism and see whether he is able to recover or not, whether there is a recovery point or not, and you have to keep on going down till the patient recovers. The difference between recovery point and breaking point is the amount of fusional convergence that patient is having. because that is the control, that is the voluntary control that patient is having. See, he has, the patient has recovered. We are going down. No, he's not. Patient is not. He's still trying. There is alternate exit still there. So that is how you measure the convergence. And how do you write it? This is how you write it. You write it. What is the breaking point? 40 prism diopters. What is the recovery point? 20 prism diopters. What is the normal convergence amplitude? 25 prism diopters. Breaking point and recovery point, 20 prism diopters. So this is how you do the fusional amplitude. Now this was a small ocular motility tester which we had devised, because this was in 2010. Because whenever we used to measure ocular movement, we used to write from 0 to -4. So if there is an adduction deficit, we will write -1, -2, and this adduction deficit used to be very subjective. It used to be very difficult to know how much was the deviation, especially in these neuro-ophthalmic patients, later like the palsy patients. It used to be very difficult to say that it was -2 then and now it is -3 or -4. So that is why we devised a small equipment, which basically there's a scale which is fit here, and you can measure the amount of deviation. And with this, we found out what is the normative data for adduction, abduction, elevation, and depression. So this we should have it in mind before we say that this particular patient has poor adduction or poor abduction. This is the range, 7 millimeters to 12 millimeters. But this is the range for Indian population. This is what we found from our instrument regarding the range of ocular motility, adduction, abduction, elevation, and depression. And this is the old article of Kastenbaum. Our values were slightly different from him. So this is all regarding motor part of strabismus evaluation. Should we continue with sensory evaluation?
Yes, sir. You can continue, sir.
I'm not. Just a minute. I think
you can continue, sir.
Okay. So basically, when we are planning for sensory, whether we have to keep him slightly ESO or we can make him ortho or not, that we have to find out. So surgical plan, post-op prognosis, whether he will have diplopia or not, all this can be found out with the help of measurement of, or finding out what is going on at the sensory level. See, motor level is when the eyes are moving, but what they are perceiving, that particular part is the sensory part. Now, way back in, I think, 60s, this particular grading was given. Now, there are no grades of binocular vision. Honestly speaking, we can't make a line in water and say that this is simultaneous perception and this is fusion and this is stereo acuity. These are all overlapping things. This all depends on how much what kind of scenario it is, whether the two eyes, whether you are doing a very dissociative test or whether you are doing a very physiological test. Like Begolini is a very physiological test. It is possible that the same patient may have very good fusion on Begolini and very poor fusion if you use red-green glasses, because red and green glasses are very dissociative. And if you do an after image test, it is possible that you may get a different result. So one thing is, whatever you are doing, keep on doing the same thing on follow-up also, because it is very important to understand that every test has an advantage, every test has a disadvantage. More physiological tests you use, better it is, because more physiological means in the normal life, you have a lot of things going on. So patient is able to manage without having a lot of struggle or a lot of problem. But when we are measuring, we are creating artificial environment to separate or to dissociate the two eyes, to understand the response from two eyes separately. Now, what are the two prerequisites for any binocular single vision? One is they should fall on corresponding retina. Second is they should be very close or very same in size and shape. Now, this is the difference between fusion and stereo acuity. Here you will have corresponding retinal elements which are stimulated, and here non-corresponding retinal elements are stimulated. You don't really need a motor system in stereo acuity, because you can keep on looking straight and you can still have the stereo acuity. Whereas in fusion, you need to fuse, you need convergence, you need divergence. This is purely two-dimensional, this is purely three-dimensional, because here the two images are and therefore stereopsis. Another important thing is that stereoacuity will almost always be horizontal, because the Panam's area is horizontal. There is something anterior, something posterior. Whereas fusion can be horizontal or vertical. You can have difference in fusion, but Panam's area, remember, it is not vertical. If it is the same horopter. So Panam's area is like this, anterior posterior. There may be a small Panam's area vertical, but mostly it is the same horopter. And it will decrease beyond 6 meters. You won't have much of stereoacuity because the Panam's area becomes very small. As you go far back, the Panam's area becomes so small that there is hardly any disparate, retina elements. The difference between the two focus is different. When it reaches 6 meters, there is not much of a difference between the two images that you get from right and left eye. So this will function equally well. You have to fuse at any distance. So this is the major difference between fusion and stereoacuity. And suppression and ARC. Now, I will be putting forth what I have understood over these years. I will not be giving you complicated things. Suppression is binocular, amblyopia is monocular. 3 days back, I was one of my friend was asking that patient has 6/6 vision. How can he have how can he have suppression? Vision 6/6 in each eye means that he doesn't have amblyopia. Suppression means that he is not using two eyes together. So suppression is binocular and poor vision, centric vision is monoocular. ARC means abnormal retinal correspondence, which means that fovea of one eye is having anomalous common visual direction with the non-fovea or non-foveating point. These two things have a common visual direction. Normally, we have bifoveal fixation. So if there is a complete adaptation, which means that if the angle is 10 prisms and if there is complete adaptation, then the subjective angle will be 0. Angle of anomaly and your objective angle. If both of them are equal, then it is harmonious ARC. Both the things, you can have very good vision in each eye and still can have ARC. So ARC suppression are binocular concepts. Amblyopia is monoocular concept. How do you test all these things? See, what we do in our practices, we do red glass test, we do Worthford dot test, we do Maddox rod and Baglaney striated glasses. We don't do haploscopic test because haploscopic test, the problem of haploscopic test is they are not real. They are under, you are simulating these tests. So they will always give you, you cannot suppress the image on after image test because you are stimulating each eye separately. So these are more physiological tests. So we do red glass test. Here you put a red glass in front of one of the eyes and ask the patient whether he is able to see two lights or not. Then we do Worthford dot test where you have, we will see this. So this is Worthford dot test. So basically what you are doing here is pretty simple. You are using red and green glasses to dissociate the two eyes and you have 4 dots, 2 green, 1 red and 1 white. Why do you have like this? To dissociate the two eyes, to know the difference whether right eye is looking or left eye is looking. Imagine the brilliance or the genius of Claude Worth. Such a simple test, but such a brilliant thought it is. You use right eye with red and you use green eye, left eye with green. Now, if what I have done is I'm using a 4 dot and I'm putting a green filter. What green filter is doing is, you will see this is the response. See, I'm putting a green filter and what do I see? I see 3 lights. This is what patient will see. The red light will be completely complementary. Why red and green? Because they are complementary colors. The moment you put a green filter, the red becomes black. And so you are not able to see the red line. What happens when you put the red filter? Obviously, the green will become black and you will see 2 red dots. I think the simplicity of this test is what makes you can 2 red dots. This is left eye suppression. The earlier one was right eye suppression. Typically, you will have red in front of right eye. So this is, once you put a red filter, you can see that it is left eye suppression. This is what a left eye suppression patient will see. So what are the disadvantages? As I said, what would happen? What would happen is that right eye and left eye will be completely dissociated. Why? Because they are complementary colors. There's 100% dissociation of the eye. This is not real. Light does not move on red and green glasses. There are enough normal clues that a patient with red green Worthford dot test may still have some binocular vision. But because this is a very dissociative test, patient may exhibit suppression. Colorblind patient may not tell the colors, but still the number can still help. They may not tell you that this is red or green, but they will tell you 2 dots, they will tell you 3 dots. So because suppression will be there. Colorblind doesn't mean that they see in black and white. They are not monochrome. Just that their color perception is different from us. Then there is Bagolini glasses. Absolutely a brilliant innovation by Bagolini. See, they have kept meridians at 45, 135. Oblique meridians are little less likely to suppress. So you will get that response. This is the typical response. The photograph has been taken from screen. And this is the typical response. You wear red, you wear the striated glasses, you take a torchlight and you will see the cross. Cross means he has good binocular vision. And if you compare the two tests, okay, I will tell you the response. Response is very easy. If your striated is like this, you will see the light like this. If this is not there, this particular eye is suppressed. And the reverse is true for other eye. If there is a central scotoma, what it means is that there is a central suppression. Now, which one to do? That is the more common question that is being asked. See, Worthford dot test will dissociate more, Bagolini will dissociate less. We can see through the glasses in Bagolini's test. So you can actually see the examiner, you can actually see everything. So it's a free space. You can still have your fusion intact with Bagolini glasses. You can use Bagolini glasses to measure cyclotropia also. Because you can turn the glasses just like in a trial set, just like a Maddox rod. You can do it with Bagolini's glasses. And then there are haploscopic tests. Basically, what you are doing is the two test objects are being placed separately to right eye and left eye. That is what happens in haploscopic tests. And that is why I'm saying that they are very dissociative. Because in normal life, both the eyes are open together. So what you are doing is you are closing one eye, presenting a stimulus to this eye, and then closing this eye and presenting the stimulus to this eye. Now that is what you do in haploscopic tests. Now, most commonly done is after image test. Now, what do you do in after image test? This is an after image test. What you are doing is you are first giving a stimulus to the right eye, the horizontal stimulus, and then you are giving a stimulus to the left eye, the vertical stimulus, and then you are asking what you are able to see when you close the eyes. Now, we will take that, but just before that, we will talk about objective angle, subjective angle, and angle of anomaly. What is objective angle? Objective angle is the angle that I am measuring. Subjective angle is the angle that patient is having. And the difference between the two is objective minus subjective. So when there is normal retinal correspondence and there is subjective angle, when they both are equal, what it means is that there is a zero difference between normal retinal correspondence and subjective angle. So the objective angle has to be equal to the angle of anomaly because subjective angle is zero. See, there is no subjective angle. Whereas here, the angle of anomaly is equal to objective angle in harmonious ARC, the same as NRC. And in unharmonious, the angle of anomaly will always be less than objective angle. I will give an example here. Before we go there, I will give an example. Suppose patient is having 10 prisms esotropia. And patient is having 10 prisms esotropia and still having binocular vision. What it means is that there is an abnormal retinal correspondence. Now, when you measure the angle, if the angle is still 10 prisms, it means that subjective angle is 0. And there is complete harmony between the two things. And if the objective angle comes out to be, say, if the patient has an angle of 10 prisms that you have already measured, that is your objective angle. And when you measure the binocular, suppose if you keep 5 prisms and patient is now having binocular vision, then that 5 prism is the subjective angle. And that is what makes it unharmonious. I think we can take this in the discussion. Now, this is what happens when there is ARC. See, this is the point which is fixating with the fovea. So what happens here is you will have uncrossed diplopia in exotropia, and you will have cross diplopia in esotropia, because your fovea is no longer, the patient is not bifoveally fixing. So what will happen? It will project in the temporal part of the retina. So that is why there is paradoxical diplopia and abnormal retinal correspondence. Now, this is a small, this is another wonderful test devised by Irwin and Jempolsky, 4-prism Bayes-out test. This is basically to rule out any monofixation syndrome or ARC. What we are doing here is we are putting 4 prisms in front of the fixing eye and in front of the non-fixing eye, and we are seeing what is the response. In front of non-fixing eye, when you put, what happens is there will be no response. In front of fixing eye, when you put, immediately there will be a movement which will be followed by other eye movement and a refixation movement. If you put it in front of left eye, okay. If you put it in front of left eye, there will be a adduction movement and an abduction movement in the right eye, and then there will be a convergence. Now see, there is no movement. So we don't know what is wrong. He is having 6/18 vision. Now we have got the prism. We are taking it from up to down to avoid any bias. Now there is no movement, right? Because this is the eye which is under suppression. There is a suppression scotoma. There is the ARC. So there will not be any movement. Now the moment you put prism in front of the left eye, you see what happens. See. Yeah. When you put it in front of left eye, the left eye adducts. I will move it again. Yeah. I move. Yeah. Left eye adducts. There is a, see, the right eye abducts, and then there is a refixation movement. See, we can see it again. It's a very beautiful test. See, I will put it in front of the left eye. It adducts, and there is a small abduction movement in the right eye, and then it re-adducts. Because left eye, the rays are, when we put the prism, what happens? The rays will shift, and to go to those rays, it will adduct. That is where it is known as a positive 4-prism Bayes-out test. Now, depth of suppression also you can measure. How much is the suppression with the help of series of red filters? You can place it in front of fixing eye till the point patient is able to see with both eyes together. Greater the number of layers, deeper the suppression. So basically what you are doing, you are reducing the vision of other eye so that the eye which is under suppression is able to see. Now, these are some of the stereoacuity tests. I'm sure everybody is using whatever they feel good. My personal favorites are Langs and Titmus. I'm not really into TNO because TNO is a very good test. It's an extremely beautiful test. It can tell you about till 15 seconds of arc, but it is a highly dissociative test. You are using red-green glasses. So I would go with Titmus. The problem of Titmus is it has a lot of monoocular clues. So where do you go? You go to Langs. Langs will not have many monoocular clues, and you don't require any special glasses. So it is much easier with younger kids. And the best is Frisbee. I've got Frisbee also. The best is Frisbee because there are absolutely no monoocular clues. There can be a problem of parallax, but it is true stereopsis. They have targets painted on one side and the back side, and you can easily see what is working where. And this is another test which you can use for stereoacuity. Lang's 2-pencil test. You can hold a pencil and tell the patient to bring the pencil and put it on the top of it. So that is another test for gross stereopsis if the patient is not cooperative. So that is all regarding evaluation of strabismus.
Very nicely explained, sir. And your videos are very good. Very beautifully explained the alternate cover test, cover, uncover test. Now, today we have got very experienced consultants amongst our panelists, Dr. Kubre sir, Dr. Dhiren. Dr. Dhiren sir, are you there? Dr. Kubre sir, Dr. Rashmi. I'd like to take your opinion, Dr. Kubre sir, how you proceed in your clinical practice. Please unmute yourself.
Am I audible?
Yes, yes.
Firstly, I would like to congratulate Dr. Jiten sir for such a wonderful, very in details, in depth, and so many things he has explained about the sensory and the motor test, function test, and that is the soul of the squint surgery. The good prediction or the post-operative outcome, the better outcome is dependent on these two things. And before that, I would tell one more thing. To examine or to evaluate before, the examiner should be sensory open. Examiner senses should also be open. There are multifactorial things that is deeply hidden in the sensory and the motor function. Sir, I would like to ask one thing that what is the utility of this synoptophore nowadays? Is it mandatory, or are you using these thing as a mandatory or not?
So, Synaptophore as such is it's a very useful device. See, I can tell you one small thing. Synaptophore is an extremely intelligent device. But the problem with Synaptophore is that it is a highly dissociating test. So what happens with Synaptophore is that, when you are using Synaptophore, both the eyes are completely dissociated. You are using Synaptophore mainly for distance. And if you are comfortable with Synaptophore, then it's a very good device, because so right now what we do is most of our work is on Synaptophore. We use it for measuring, fixing right eye, fixing left eye, and in 9 gaze. That is the maximum which we are doing with Synaptophore at this point of time.
Right, sir. Thank you.
Viren sir, any comment?
Yes. Dr. Biren sir,
Yes, ma'am.
will you
Sir,
like to
your
comment?
comment, please.
Jitu bhai explained everything very in depth and very detailed. So he has not left anything for us to comment. So I think evaluation sensory part is very important, because some long term this thing outcome depends on our sensory part, because motor part we all of us can take care of, but sometimes we forget about sensory thing, which is very important for predicting long term outcomes. Sometimes we intervene in very early stage, and we have seen 10 year down the line there is a consecutive kind of squint. So that is something which is important. So Jitu bhai, I would just like to ask, what do you think about long-term outcome of any intervention in squint?
Long-term outcome means,
Means you have operated a patient maybe around 3 years of age, and
yes.
patient is again coming to you at the age of 15, and you are surprised with the outcome at that point of time, because maybe for a couple of years patient was well aligned, almost normal. So when it was badly needed, that time we see surprises.
Yeah, see, actually, most of these patients who come back with surprise, no, they have not developed binocular vision. If once they develop the binocular vision, then their brain is able to hold. The problem is they don't come back for follow-ups. As you said that you have operated at 5 years, patient comes back after 5 years. So if the patient was, suppose we have operated a patient for infantile esotropia, we have done a bimedial recession and bilateral infraoblique recession. Now this patient, we all know that, we have robbed him of total convergence. So he is going to come back to us of time. We could have reduced his hyperopic glasses. We could have put him on anti-suppression. We could have done alternate patching. Maybe he was having amblyopia in one of the eyes. So the problem is that there is a long-term follow-up when you operate patients at less than 18 years of age. Once they are about 20, if you operate a patient of 25 years old, more or less they remain pretty stable, except for intermittent exotropia.
And how early do you intervene in congenital ET?
Actually, I think I think bulk of the problem is not the doctors. Bulk of the problem is not the patient. Bulk of the problem is parents. The parents don't want us to intervene before 1 year, and we keep on telling them that I have the youngest I have operated is 8 months. But we keep telling all the patients that, you have to get him operated as early as possible. So the youngest I have operated is 8 months, but quite frequent. And my fixation is not really towards doing bimedial recession, because I have seen that a lot of patients very easily go into exotropia after long term. I can say this after 20 years of my practice. I can tell that a lot of patients initially, when we did bimedial recession, gradually they go into consecutive exotropia. Patients who were residual esotropias become ortho, or they become good. I'm talking about residual esotropia of 12 prisms, 14 prisms, when patients parents were thinking that we have not done a good job. And gradually over a period of 10 years, those are the patients who become straight. Partially accommodative esotropes, where we have done bimedial recession, they are the most notorious. They
Wait to intervene in a case of amblyopic eyes, actually? For how long we have to treat the amblyopia?
So, so for that, for me, it is quite clear. Patient comes to us, we do cycloplegic refraction, we see if there is amblyopia, we treat the amblyopia. We treat the amblyopia completely till it is 6/9 or at least 6/12. Once it is 6/12, we don't wait for anything. We operate the patient, make him straight. Once the patient's straight, we put him on anti-suppression, either dioptic glasses or chiroscope. And we tell them that this will go for another 6 to 8 months, and the follow-up will be there every 6 months. If the patient goes back into amblyopia, we treat with patching and try to find out why he is becoming amblyopic. When both the eyes are straight, why he is going into amblyopia, if there is any anisometropia, or if there is a residual squint. So that is what we do in patients with amblyopia and strabismus.
Right, sir. In case of monoocular vision, what precaution we should take, sir?
Monoocular vision, honestly speaking, they are best left alone. because with nature and with God, they are at peace. So monoocular fixation are a little difficult, little tricky. So that's the reason I put 4 prism base out test in this, because if you treat them, and if they go into if their suppression scotoma goes away, then they have got paradoxical diplopia. Then it becomes very difficult to treat them, because they will have very small angle. They will have 6 prisms. It's very difficult to operate for that 6 prism, and that is what is typically termed as intractable diplopia, because you are doing cover test, there is hardly any deviation, and patient is complaining of diplopia. He's constantly saying, no, there is another image. So monoocular, if you have a monoocular fixation patient, it is best to tell him that this is the optimum that you have already got. And if you want to treat the patient, you tell them that there is a chance of intractable diplopia.
Right. And in an early age, can we try that exercise, orthopic exercise first? Then
yes, you can try, but if the child is less than 6 years.
Right.
Dr. R.K. Gupta, you have some questions?
Yes.
Please unmute yourself.
Thank you, sir.
It is amblyopia only.
Dr. Gupta, you want to ask something?
Excuse me, I just want to make a comment.
Yes, Rashmi. We are waiting for
regarding synaptophore. Yeah, regarding synaptophore, I think it is very good thing to know the subjective angle of squint and objective angle of squint, and to know the ARC very early stage. So when we were using synaptophore, we usually came to know exactly ये जो हम formula we are reading, subjective minus objective is the angle of anomaly. So that is very easily possible with synaptophore. Secondly, its role in exercising. That was also very important. And regarding infantile ESOs, it should be operated as early as possible. But yes, I'm 100% convinced with Dr. Jitendra that parents are not ready to give their consent. And for that infantile ESOs, we are not still waiting for amblyopia therapy and vision to be equal in both the eyes. Still, it's better to operate early. Thank you.
Nicely explained, Rashmi. Dr. R.K. Gupta, you have some questions?
Yeah, am I audible?
Yes, you are audible.
Yeah, my question to Dr. Jitendra Jethani, that if the patient of the amblyopia comes at the age of 10 years, so can the occlusion treatment be effective in that age or not?
Yes, sir. Yes, sir. 100%, sir.
Sir, what
Sir,
is the
how much is
maximum
the
age?
maximum age? Yes, what is the
No,
maximum age
there is
for?
no, sir. There is no cutoff. So if you have a patient of 20-year-old, and if the patient is having 624 vision, it is
Yes.
always good to talk with the patient and tell the patient that, okay, do you want to patch? Whatever the age, there will be some improvement. 1 line, 2 line, 3 line, that all depends how much he is patching, how bad, how much is the plastic phase. But if the kid is less than 15 years, tab to we should always give patching.
I think myop will have better outcome after this, because one of my patient I started at the age of 24. She was 636 and she improved to 6'9". She was
They
myop.
improve, sir. A lot of patients will improve. If you if you see them objectively, what happens is that here I would say the problem is with us. A lot of times we only feel ki ab to kya, matlab, the age is too much, now you leave it. But normally they give good response. They improve.
Okay.
So
Sir,
one question.
one thing you, okay. Yes, yes, carry on.
Yeah.
Sir.
I want panelists and Dr. Jethani and all panelists that one newer module is coming, that exercise on computer online they are offering us. Someone came to me just a few weeks back. They are having some exercises on the computer. So refer your patient for that. Any experience of any one of them, and what is that exactly?
So there are, I would answer it first. There are three major softwares which are running around. One is Revital Vision, which is basically a Israeli company, and those are basically based on Gabber patches. They are mainly into amblyopia therapy. They are not into binocular therapy. Second is Binox, which is made by Binox people. Oli and his group is promoting it. That is a copy of even a better version of VTS4, VTS5. Basically, it is a 3D TV, or rather a 3D image, which is dissociated with red and blue. As we discussed, red and blue. That is known as dioptic stimulation. There are some free games available online also, where you can use red-blue glasses and do those exercises. This one, basically what they are doing is they are using both the eyes together. So 50% is being used by right eye, 50% by left eye. So that is the principle, that both the eyes are working together and it will stimulate the vision. The third is Cure and See, which recently was presenting their work in Shark Tank, and I think Mr. Piyush Bansal
Yes.
has some stake now into it.
Yes.
So
Yes.
Cure and See basically has a software which is I wouldn't say copy, but it is very similar to Binox, very similar to Revital. They have different modules. What they have done is they've copied everything and kept it at a single portal. So you can either use Revital, you can either use Binox, you can use dioptic stimulation, red, blue, red, green, everything is there in that. My personal experience has been with all three of them. I think Revital Vision is a good system for amblyopia. Binox works in some patients, does not work in some patient. But despite all this, I would say that patching is the gold standard. With patching, the vision improves fastest. With patching, we are closing the better eye. So we are getting 100% stimulation to the amblyopic eye. So patching, all the studies, they will show some old studies where they say that the dioptic stimulation is better than patching. Patching initially is very good. You can give binocular exercises with partial patching or part-time occlusion, so that binocular vision is also stimulated. But if we want to improve the vision, patching remains the gold standard. If we want to improve the binocular vision, we can go with these computer-based exercises.
So this
Dr.
patching is
Kavita?
for
Yes,
intermittent,
yes.
or it is a full time?
Sir, sir, I want to share one opinion that one of my patient, I prescribed Revital Vision, and that child is from Hoshangabad, and that child showed the tremendous improvement. It's fine, and that child was 17-year-old. But one of my patient is from Vidisha, sir, and this patient is having accommodative esotropia. So when I inquired from Revital Vision Therapy people, they told me that first you correct the
strabismus.
Yeah, then only you prescribe. So my question to you is,
Your voice is breaking.
is that situation is yes?
You're not audible,
Okay.
Kavita.
No, I think I got the
Yes,
question whether we should
sir.
operate first or do
Then-
amblyopia therapy first.
Yes, yes.
Sir,
Yes, ma'am. So basically,
my question.
what we
Jiten sir,
You can go ahead with the query, sir.
Yeah. So the point is that we have to patch first and improve as much as possible. No kind of therapy can help more than patching. If there is strabismic amblyopia, which I'm sure partially accommodative esotrope will have strabismic amblyopia, you have to patch. No exercise will work. Even the binocs people will give some prisms and will try to stimulate that eye. But so there are two distinct divisions here. If we are talking about anisometropic amblyopia, we have to we can go with any of the software. If we are going for strabismic amblyopia, we have to go with patching, and whatever maximum vision we get after patching, we can get, and then we can operate the patient. Whatever residual amblyopia, despite our best efforts of patching, whatever remains can be taken care by revital vision, and then binocular vision can be started with the binocular.
Dr. Jiten sir, I got
Yes,
one
ma'am.
query about synaptophore. We have got 3 types of slides, right? For simultaneous perception,
Yes.
fusion, and
Yes.
stereopsis. So with the help of synaptophore, are we not demarcating the clear difference between the 3 stages of binocular vision? Though it may not happen in day-to-day life. Is it not good to demonstrate 3 stages of binocular vision, 3 grades of binocular vision, like where simultaneous perception, fusion, and stereopsis, with the help of 3 slides, 3 pair of slides which we have? In day-to-day life, it might be we might be getting the mixed picture, but with the synaptophore, are we able to demarcate this?
Yes, you can demarcate it, madam. Madam, every test we have to write. If we are writing simultaneous macular perception, fusion, and stereo acuity, we have to write that this was done on a synaptophore, and it can be done only on a synaptophore. If we are talking about
Yes,
simultaneous macular perception, so that is fine.
No
I mean,
other device.
yeah, there is
No
no
other
other device.
Yes.
Yeah, there is no other device to say that we can differentiate between the 3 things.
Yes. Now we have postgraduates also.
they
Dr.
can ask the
Aditi,
question.
yes, you all can ask the questions. Aditi, Yashaswini, Natasha, are you there? Aditi, do you have any questions to ask?
Yes, Aditi, unmute yourself.
Unmute yourself first.
Good evening, everyone. My question is when, like at a postgraduate level, when patient comes to the OPD, we generally focus on the motor examination. Like on the sensory part, it's a little weak. So
I think the best thing that we can do for sensory thing is that we can what we can do is we can do a Worthford dot test or a Baggellini striated glasses test and a Lang stereo test. That will suffice. These 2 things will tell you about the binocular status of the patient, and they will
Yes.
also tell you straightforward about his stereo acuity. So these 2 tests are more than sufficient.
thank you, sir.
I think after this talk, they will start giving attention to sensory part also, sir.
Yes.
This will definitely improve their clinical diagnostic skills. Yashaswini, do you have any questions? Anyone?
Actually, when I was appearing for my exam, na, so
Yeah.
I was little stuck in this word.
Yes.
With our Snellen chart, we can do it well.
Yes.
And
I think-
with Worthford test, if we are doing stereo acuity test, it suffices.
Yes.
It is complete. Like
Yes.
Worthford test will tell you the suppression or diplopia part, and then stereo acuity is judged by stereo test.
Are there any questions from postgraduates? Anyone has got any queries?
Ma'am, ma'am,
Yes,
all
Aditi.
the tests. Ma'am, can I ask?
Yes.
Yes,
Yes.
Aditi, go ahead.
Ma'am, all the tests we are performing has to be performed for near vision and the distant vision. So what is the separately performed? So what is the consequence or what is the outcome of the on the surgery or prognosis of result? How we will draw conclusion out of it? Of what?
Yes, Dr. Rashmi, are you there?
Yeah. Actually, all these tests help in prognosticating the parents. Like how much you will get. Like you are operating a child, what will you get? Are you giving the child stereo depth perception? What are you giving? Suppose, like if we are judging the AC by ratio, how much? What are the chances that the child will again go in squint? So these help in prognosticating, basically.
Okay, Dr. Rashmi, is it not like this that we are going to get the maximum amount of squint if we are going to check it for distance and for near? Specifically in esotropias or
yes,
where we
if
are
we are
expecting
checking,
accommodative element?
yes, we can categorize the squint like in exotropias also. If we are checking the amount of deviation for distance, amount of deviation for near, with patch, with breaking diffusion, so that will categorize the squint, what kind of exotropia it is, and ultimately it all helps in prognosticating. How many muscles we have to touch, what muscles we have to touch, so that helps. Thank you.
Okay. So
That,
I
that
think
will help you in the surgical plan, basically, for distance and near. Is it
Yes,
that,
sir.
Dr. Rashmi?
Yes, sir.
Suppose it is more for distance, then probably you'll take some other muscles, and if it is for
Yes,
near,
sir.
you'll take
Because exotropia is categorized according to that only. If it is more for distance, it is divergence excess. If it is more for near, it is convergence weakness. If the difference is not much, it is basic. So if divergence excess variety is there, you have to touch lateral rectus. If convergence weakness is there, you have to touch medial rectus. If basic, then it's medial and lateral both. And you have to rule out simulated divergence excess, because if in that case you are touching the patient in high AC by A ratio, there are high chances of going again.
Actually, this is what Dr. Aditi wanted to know about.
yes. So any queries? Yeah, shall we conclude, sir?
Yes, Dr. Krishna is having something to ask.
Dr.
Yes,
Krishna?
ma'am.
Yes.
Good evening, all. Ma'am, what is the endpoint of patching? Like, when will we know that this is the maximum that the patient can have? If patient is having 612, then it will not further improve.
When the vision in both eyes is equal, that is the endpoint.
And also, ma'am, till what period we have to continue patching after improvement?
For maintenance, it is to be done. Yes. If the age is with more plasticity, like till 8 years of age, you have to continue.
Thank you.
Jitendra sir, आप है भी? Dr. Jitendra?
I think he is not there.
No, he's there.
For the patching part,
yes,
we can continue the patching till the vision improves, as madam said. Second most important thing is that we have to see whether binocular vision is developed or not. If the binocular vision is not developed, then there is a possibility that the amblyopia will come back. So we have to go for binocular vision, and then we can gradually taper the patching. So that is where the role of anti-suppression exercises and all the softwares come, because they can help you in improving the binocular vision.
Yes, definitely.
Dr. Nikita want to ask something. Unmute yourself.
Nikita, do you have some questions?
No?
So I hope that all the queries are over, and Dr. Jitendra has made such a difficult topic and he has presented so beautifully. He made the thing so easier and I think it is going to be very useful to all the postgraduates. So now it's time to take
for me also.
Yes,
Not only
for everyone
for
of
me
us.
also.
Yes. So thank you so much, Dr. Jiten, for sparing your valuable time. I'd like to thank all the panelists, Dr. Kubre sir, Dr. Rashmi, Dr. Kavita, and Dr. Biren sir, and Dr. Praveen. So, and I would like to thank all the postgraduates for their active participation. And I'm sure that this class is definitely is going to add value to their diagnostic skills. So thank you so much. Thank you, everyone. Thank you, Dr. Gupta, sir. And I hope that we'll like to see more and more such type of classes in future, and we'll keep making it more and more interactive. Thank you. Thanks a lot.
जिनको डॉक्टर जितेंद्र से और सीखना है वो जैन चले जाएं.
Thank you, ma'am.
Yes,
Thank you, sir.
yes. Yes, see you all in Ujjain then.
Thank you so much, sir. Thank you so much.
Thank you. Thank you,
But
Dr.
before
Jiten.
that, we all are meeting for our postgraduate quiz on 13th. That is on in context to World Sight Day. So thank you once again.
Thank you. Thank you, everyone. Thank you, Dr. Jiten.
Thank you, sir.
Thank you, Dr.
Thank you,
Kubre.
Dr. Jiten, sir.
Thank you, sir. Thank you.
Yes, boss. Dr. Pankaj, sir, thank you.
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you,
प्रवीण
Pankaj.
सर अगर है तो
Thank you, sir. Yes, sir.
Praveen,
Of course.
पंकज सर आप आ जाते हो हमारे को दिल खुश हो जाता है यार.
yes, Pankaj.
एंड यू आर वेरी डॉक्टर गुप्ता जी धन्यवाद.
He is always there.
ये पंकज सर तो यार मेरे को मजा आ जाता देख के. एंड अवर ऑल
Pankaj?
पोस्ट ग्रेजुएट अच्छा है. इसी
Yes.
बहाने सबको हम लोगों को भी सीखने का मौका मिल रहा है.
Yes,
गोयल
yes.
सर थे बीच में अभी दिख नहीं रहे मेरे को पर डॉक्टर नेहा वाज देयर. सो मेनी आवर मेंबर्स वर देयर. Thank you, Dr. Rashmi, Dr. Kavita. Thank you so much for
Thank you,
helping us.
sir. Thank you, madam.
And bye bye everyone.
Thank you so much. Bye, everyone.
Bye
Bye,
everyone.
bye, Pankaj. Bye.
Thank you.
See
Bye.
you soon.
Thank you, sir. Thank you, ma'am.
Bye-bye.
Okay.